All right, here comes everybody. Welcome, welcome. Happy Wednesday, everybody, from beautiful Austin, Texas. All right. Hey, Grant's here. Hey, Pamela. All right. Leo from Australia. Hi to my man. Jerry's here. Hi, Carol. Is it Ida? Or is that Ida? Is that how you say it? Nice to see you. Bill McCracken's here. Catherine's here. Hey, Mary. Good to see you. June, I don't recognize you. Might be a new one. So, back there. And John's here. Good to see you, John. Roberta Watts, Cheryl. Hi, Cheryl. Bill. Leslie's here. Good to see you, Leslie. And Don. Margaret. Hey, Margaret. In San Francisco, I see Linda's here. James Wright. Francisco. Tom. Stephen. Aaron May. Doug Stevens. Susan Harris. Monique Davis. We got some new faces here today. Ernie Zara. David McKenzie. Hey, David. Hey, Alan. Andy, Charles, Sally Cox. Hey, Sally, good to see you. Geez, people are coming in. JM, Perizek, Hal, Grant. Nice to see you, Grant. Looks like a new face. Sandra, John Burns, Rochelle, Catherine, Bruce, Edward, Elaine, Phyllis. Welcome, everybody. Welcome. Happy Wednesday to you. Terry, Kelly Murph, Janet. Wow, we got a lot of people here. Let's see here. Well, they're just coming in. I don't think I can get to everybody. Kenneth and Michelle and Tom, Janet. Wow. Come on in, everybody. I'm just going to chat a little bit while everybody's coming in. We got a full house as usual. Good to see everybody. Looks like we've got some new faces, which is great to see. I'm going to let people come in a little bit more before we get started. Let's see. QB, I just saw you come on. QB, if you could put your email address in the chat area, because you asked me for that presentation about 3 weeks ago, and so I just don't have your email.
Thank you, Dan. Remember that. I'll put you there.
You're welcome. You're welcome. All right, everybody. Let's see what we got here. We got some new faces.
Hey, Dan.
All right.
Sally,
Yes.
quick question. Is this videotape going to be available? I had a few people in our group that weren't available at this time, but were interested in the presentation by the doctor.
We'll see what we can do. As you know, the HIPAA laws, so we can probably cut the presentation until we get the interaction. So we'll see if we can get that done. Good question.
Thank you.
You're so welcome. All right, everybody, we're going to get started here real quick. We've got a full house as usual. I'm just going to, those of you, let me see here. We got a speaker. All right. I'm going to put you on the gallery view so I can see as many as possible. If you're here for the first time, if you could just wave your hand in the screen so I can see you. Yeah, we got a few new faces. Good to see you. Wow, that's awesome. Awesome, awesome. Well, I'm going to introduce myself. My name is Dan Lear. I am the host, if you will, of this Wednesday session, our educational and empowerment session for amyloidosis. Good or bad, I'm here every week. So I am your host today. I'm also a patient. I was diagnosed in 2017 with cardiac AL amyloidosis. I went through 3 types of treatment over a 2-year period. And then I was switched on to a drug called Venclexta or venetoclax. And I've got what's called the chromosome 1114 translocation. And what that means is the top of the chromosomes actually switched spaces, which is just bizarre in nature. But because of that, my body responds well to the Venclexta. And so I've been on that drug since 2019, and I'm just holding steady. My light chain proteins are just above normal. They've been hanging out there for quite some time. So I'm excited to be here, and I love sharing our tools and our specialists with this group because I know that all of you are in different places, whether you just got diagnosed or you've been at it for a while. And I know it's we all go through our ups and downs. So this is a great place for everybody to meet and connect. And if you're here for the first time, I encourage you to connect with people. So here's how we typically run things. We typically have some kind of an expert, and we have Dr. Heather Landau today, which we're very, very blessed. And I'm going to introduce her in about a minute. And so we have our expert, speak for about 15 minutes, give or take. And then we open it up for questions and discussions. So how we do it is if you take your cursor down to the bottom of the screen, you'll see a hand raise icon. And so when we go live to ask Dr. Landau questions, if you just hit the hand raise icon, I will see it. And then I'll call on people in order to communicate. And because we have so many people here, I would just like to coach you to ask the question you'd like to ask rather than telling the story before the question. So just because of the time that we have, and we want to make everybody have the time to speak to her if possible. So with that in mind, I am going to introduce Dr. Landau. So hold on one sec. Dr. Heather Landau is a board certified oncologist and hematologist with Memorial Sloan Kettering Cancer Centers and works as part of a multidisciplinary team caring for patients with hematologic disorders. She has a special interest and expertise in treating patients with disorders that arise in white blood cells called plasma cells, including multiple myeloma and light chain amyloidosis. She's also a bone marrow transplant specialist and a cellular therapy specialist, and is a doctor with special training in using cell therapies to treat health conditions such as cancer. Therapies can include antigen receptors like CAR T cell therapy, which is one of the top hot topics that people like to talk about. Today, Dr. Heather Landau's talk is titled Removing Amyloid, Breakthroughs and Barriers. And she's going to talk about the challenges and the breakthroughs in clearing amyloid from organs and what's happening in today's medical field in regards to that. So with that in mind, if you could please, even though you're on mute, put your hands together for Dr. Heather Landau. All right. Dr. Landau may be on mute.
Can I share my screen?
There you go. I got you.
Sorry.
You're fine. You're fine.
Thank you so much for this. And I am now going, thank you for that wonderful, kind introduction. I'm going to share my screen. Let me know if you can see it.
Got it. We got it.
So I am going to talk about, as Dan said, removing amyloid breakthroughs and barriers. I wish we had more breakthroughs than barriers, but I was asked to talk about this topic, and a lot's gone on, so I will tell you where we're at. But good news is we have lots of breakthroughs despite all these challenges. So I'm just going to run through a little bit of the pathophysiology of both ATTR and AL amyloid, because I don't know what kind of mix of the patients, but I assume there is a mix. Light chain amyloid is a plasma cell disorder that starts in the bone marrow. It produces plasma cells, and these plasma cells, usually plasma cells, sometimes they could be lymphoma type cells, and they make antibodies, and these antibodies or parts of these antibodies can misfold into these amyloid fibrils that deposit in the different organs, like the heart, the kidneys, the liver, the nervous system, and cause organ dysfunction from that deposition. While ATTR also causes amyloid, it's a very different process. And this TTR, this transthyretin molecule, is produced in the liver, and it's produced as it takes on this conformation as tetramers. But for unclear reasons, these tetramers can dissociate into monomers, and these monomers, these parts of these tetramers, then also have the capacity to misfold into this amyloid fibrils. By this point, they look very similar. They're both amyloid, but they obviously come from very different places. But TTR amyloid tends to affect the heart and the nervous system. And when we talk about treatment, to date, treatment for AL amyloidosis has been has been directed at the plasma cells, the factory that's producing these amyloid light chains. The plasma cells are the lymphoma cells that produce the amyloid light chain. And it doesn't really get rid of the amyloid that's already been deposited, but it gets rid of the factory producing these light chains to inhibit new fibril production. Standard of care for TTR amyloid there's drugs that either TTR silencers, meaning it turns off the gene. These silencers turn off the gene that produce these tetramers. And that can be effective, or tetramer stabilizer. So if these are tetramers, that means that there's 4 different parts to it, and it has to, remember, become monomers to make amyloid. So if we can keep them as tetramers, then they don't have the ability to become monomers. So both, so these also inhibit the new fibril production, but it does not get rid of the amyloid that's already deposited. So there are no currently approved therapies that deplete amyloid fibrils deposited in organs. And the issue is that if we turn off the factory that's producing the amyloid, again, the organs, we expect the organs not to get worse, but in some cases, they don't necessarily get better. They do usually get better only because they're not having this continuous insult. But again, it doesn't get rid of the amyloid that's already deposited. There have been attempts at producing antibodies that are directed against the amyloid themselves. And if we can mark them with something abnormal, our immune system, which is responsible for getting rid of external invaders like viruses or bacteria or any cancer, anything abnormal, if we can mark them with antibodies, we can use our own immune system to get rid of it and get rid of these amyloid that's already deposited. The assumption is that we can get rid of the amyloid that's already deposited in the organs. And so in AL, there's been several different attempts at trying to do this. And well, the first drug was actually against a molecule called SAP. And that was a labor of love from an investigator in the UK who made anti-SAP antibodies. And that's a long story, but he spent his whole career, and they had these SAP scans in the UK that showed that if you use these antibodies against SAP, your SAP scan, which showed that lit up with all this amyloid, could be depleted. But then when it was tried in humans, maybe it worked too well because it was too toxic and the whole program was shut down. So the SAP antibody has been gone for a long time. Then there's 3 other antibodies that were produced that bind different components of the light chain. And the first was NeoD001 or bertamimab. And the initial studies showed excellent responses in almost 60% of patients with cardiac and renal responses. But the way that we designed that trial, patients had to have had a good response, hematologic response, meaning we got rid of the plasma cells before they could go on this drug. And it looked like it worked beautifully. But then when we did it in the upfront setting, the study was terminated early for futility. However, when the company analyzed the data, they thought that there was a subgroup that may benefit, and that study was then performed in a subgroup of patients. Similarly, the Kale 101 is an antibody against the misfolded light chains, and the initial reports in a small subset of patients showed an 80% cardiac response. But again, that study required patients to be in a hematologic response before getting this antibody. And now the phase 3 trials are ongoing. And then a third drug, a more potent antibody, meaning it binds tighter to these amyloid fibrils, has been developed, and the first in human studies were conducted and were being conducted in Australia. So although there's been several efforts, the bad news is this drug was recently, the study was stopped because for futility. This third study was stopped for futility. And this study, there was a press release last week that the study did not meet its primary endpoint. So we were all very, very excited about all of these drugs. The question is, why don't these drugs work? And I don't think we know. I don't know, amyloid is AL amyloidosis is a very complex disease. Everybody with AL has very different organ involvement. Are we choosing the right patients for these studies? Does this actually only work in mice, but it doesn't work in humans? I don't really have the answers, and I wish I can't come here saying that we just made major breakthroughs and this is going to be available to everybody. I wish this was the case. The other question is, maybe our anti-plasma cell therapy is just so good that this doesn't have, because when we start treating these patients, we also treat them with now daratumumab based therapy, and it's really been hugely successful for our patients. Not everybody, but 60% of our patients will get into a complete response, and the organs can recover. It just takes a long, long time. And I don't really have the answers, but I would say the good news is that our anti-plasma cell therapy is even getting better and better and better. So that's the good news, and maybe our patients are doing better, and that's why these studies were negative, because the patients on both the bertamimab study and the Kale 101 study are doing better than they had expected. So that's amyloid-directed therapy in AL. The bertamimab, the Kale 101 study is still ongoing because they think that there may be a subset of patients who are benefiting. That was only being done in patients with advanced cardiac disease. Maybe it doesn't work because patients were too advanced and there was too much amyloid and this doesn't work. But I don't have the answers, and I wish I did. But I can say that nobody's giving up to find other ways to facilitate removal of amyloid fibrils. I would say the most novel way that folks are thinking about this is, it's been revolutionary, the way that CAR T cells, chimeric antigen receptor T cells, have been very transformative in the plasma cell disorder and hematologic, for patients with hematologic disease. And there are efforts to develop cells that could potentially be engineered to not just the antibody that labels the amyloid, but cells to be engineered to remove the amyloid. So nobody's giving up. We're just not there yet. So there's also 2 drugs in development for TTR. I don't want to leave you guys out because, again, these are just much earlier in development. Again, the preclinical models, in mice, these work beautifully. In the phase 1 of there's Neuroimmune, and there is another company that is escaping me at this time that is developing the second antibody, but there's in the phase 1 study, there's some data that suggests that this could be helpful. But again, when you start with small numbers of patients, it's really hard to interpret the data. But these studies are ongoing, and there is possibility that perhaps it works in ATTR, even though it didn't work in AL so far. There's also a novel approach in AL amyloid, just like in TTR. When our plasma cells or lymphoma cells make these antibodies, they do have to unfold before they refold into this amyloid substance. And if we can find drugs that keep them from unfolding like we do in TTR, we might be able to prevent amyloid fibrils. My final thoughts: nothing replaces the importance of early diagnosis, because if you diagnose the disease earlier, if you present and you have less disease, then you have less organ involvement and you are easier to treat. And participation in clinical trials, even if they're negative, is really essential, because that's the only way we're going to forward the field. In AL and in TTR, we've only had our first approvals in these diseases in the last few years, which is, worlds of, very transformative for these fields, but it takes a long time and a lot of effort, and participating in clinical trials is really the only way that we'll get these drugs to market. But I do want to leave you with my final thought. I do think the future ahead is bright. I can speak, again, I treat AL predominantly, and the way daratumumab was a huge breakthrough, and I can say that I think that we're going to be gifted with even more powerful drugs for at least the plasma cell disease. And if we could recognize the disease early, get the plasma cell disorder under control earlier, we will make a difference in the organ dysfunction. That's it.
Awesome. Thank you, Dr. Landau. I appreciate that. At this point, we're going to open it up for questions, and we'll start out with Leslie. You're on mute right now, Leslie. There we go.
Thank you so much. It was wonderful hearing you. Now, my question is, who is an ideal candidate with AL amyloidosis for the CAR T trial?
So currently, we are the only people who are doing the CAR T cell trial. So the CAR T cell trial is the CAR T cell is directed against the abnormal plasma cells. If you're in remission but still have organ involvement, then the CAR T cells aren't going to help you. So patients who need CAR T cells are patients who are either didn't get into a good remission with their upfront therapy, with most commonly is Dara VCD, or that Dara Cybor D regimen, or if you have translocation 1114, we often use, as Dan said, venetoclax. If you don't get into a remission, or after you get into a remission, then you have worsening light chain levels, that's who is ideal for the CAR T cell trial.
Okay, because my hematologist oncologist was thinking that I could be a candidate. She's at Duke, and Duke supposedly is supposed to be doing these trials, but it's not open currently, right?
Yeah, so so we're doing the first trial with the Nexella
I knew.
product. Soon, there's another AZD, AstraZeneca or Alexion will be doing that here as well. That is another trial that will be open soon and that may be available at Duke. And if you are either had if you did not have an ideal response to initial therapy, or if you are relapsing, that would be an ideal trial to go on.
Okay, just one last thing. Dara stopped working for me, so I'm on venetoclax. And my light chains are good, but my kidney function isn't doing so good.
Well, then you're not if your light chains are good, then that means that your plasma cells are controlled and you probably aren't a candidate for the CAR T cells. The problem is that when the amyloid deposits in the kidneys, sometimes, most of the time, they get better, but not every time.
Okay.
And it depends where in the kidneys that those amyloid proteins deposit.
Mm-hmm.
But
Okay.
if your hematologic disease is controlled, so I have more of a story for you for that. If your hematologic disease is controlled, another thing I'm very passionate about, if your hematologic disease is controlled, but your organs are still not doing so well, especially if your kidney function is deteriorating and it's like you might need dialysis, we have a very robust program getting patients kidney transplants.
Oh, I don't think I'm there, but it's good to know.
Yes.
Awesome. Thank you, Leslie.
Thank you.
All right, QB, you're up.
Hello, thank you, Dr. Landau, for joining us and share with the good news and not so good news, but the encouraging words. I have a question. I'm aware that the Q101 failed to meet any point, so my immediate, next stage of, hope, shut down. I have AL in my heart, so my question this, it's been bugging me for some time. Since the fiber already deposited in my heart, as I'm waiting for the fiber removing magical pills, what is the pathogenesis? How long can my heart sustain, before it can, is it still reversible at all?
Yeah, so I don't call it reversible, but many people can live with their amyloid in their heart as long as it's not continuously if amyloid is in your heart, it's not going to become perfectly normal again. I'm not going to pretend that's the case. But if you stop getting the hematologic disease is controlled and you don't have the constant deposition or insult from ongoing deposition, then you do get better and you feel better. You have to rehab and you have to work on it. But patients do get better, but your heart doesn't become normal and there's risks of arrhythmia and there's other things that can happen. But if you have a good cardiologist managing you and a good hematologist getting the disease under control, I have seen very sick patients with very bad hearts live very normal lives.
Thank you. That's again encouraging word.
And
So
again, sometimes you can have organ damage in the heart to the point of no return. And even if you're in remission, there just was so much damage that your heart continues to deteriorate. And then we get you a heart transplant.
So my concern really, that's a fibro eventually, become a huge scar in the heart, between the heart muscle. Honestly, even the fiber removing drugs approved, it become useless, isn't it?
I can't predict the future. I don't know.
All right, thank you. I appreciate that. Thank you.
All right, QB, thank you. And please remember to put your email address in the chat box for me.
I did already. Thank you. Thank you.
Oh, okay. Martin, you're up.
Hi, doctor. My question, which you may need some background on, is what are the go-forward treatment options for for keeping, in this case, my wife in long-term remission? She's started off on, the standard of care. Then after 2 cycles, that doesn't work, and we switched out Velcade and cyclophosphamide for venetoclax. Venetoclax seemed to have worked very well. We're almost at the end of the 6th cycle, and the light chains are roughly 15, 4, and a 0.27 ratio. So fairly good numbers. So my question here is, how do we go forward? I heard Dan has been on Venclexa, approximately 6 years. Is just staying on Venclexa an option? Are there side effects for that? Do you eliminate DARA because DARA didn't work? So
I would
we have.
eliminate,
Go ahead.
I would eliminate DARA because DARA didn't work. I would stay on, I usually do venetoclax for 2 years, and then I check the bone marrow. I see if they're in remission. I see if, how deep the remission, how good the organ response is. And I don't usually keep patients on forever if their light chains are normal. If
So
they're, yeah.
So after 2 years, you feel comfortable enough that if the light chains
I am
stayed,
talking in a gross,
of course,
in a, not for any one individual. I
yes,
can't say I've never kept patients on venetoclax for longer. I can't say I've kept, I can say I've kept patients on venetoclax for shorter. Some people who go into a very deep remission very quickly and then don't, patients who go into a remission very quickly, which is, not everybody, but if you go in very quickly and then you have some fatigue or something like that, I don't keep you on forever.
right. Under what circumstance would you do the transplant?
The stem cell transplant?
Yes.
Yeah, so this is a very nuanced question because I spent my whole career transplanting patients for this disease. And I've really a little bit changed my tune because I would, if somebody is not in remission, I would consider a transplant. But these CAR T cells and these bispecific antibodies that are coming down the pike are really quite a bit even more effective than stem cell transplant, and they're actually better tolerated. So they have unique toxicities, but at the same time, I can say that I am overwhelmingly optimistic that we will be doing less and less transplants for patients with amyloid because the CAR T cells and the bispecific antibodies are so effective. So I
Yeah.
think that your wife's situation can stop the therapy, try to live a normal life without being on therapy. If she relapses or progresses at some point, there will be an opportunity for her to get alternative therapy, perhaps venetoclax again, if she was one of those super responders, perhaps transplant or CAR T cells, depending on where you live and what's available.
Right. Have you had any experience with long-term side effects from venetoclax?
Not really.
Okay.
Most people tolerate it really fine. Some people have fatigue. There's nobody who I take off the drug and they are still suffering from venetoclax toxicity. I wouldn't say.
Mm-hmm. Okay. Thank you.
Thank you, Martin. I'm going to read before I go to you, David, I'm going to read a quick question from the chat. Dr. Landau, the question is, you noted that DARA and other anti-plasma cell treatments are working so well that it may impact some of the removal treatments. but it takes a very long time for organs to recover. Does this mean eventually that with time, the body itself can remove a significant portion of amyloid deposits from the affect organs? Are there any long-term studies looking at this?
Yeah, so I believe, and we don't have a lot of data on this, but I do believe that it's not, the organs get better and it takes months to years, but it's not because our own bodies get rid of the amyloid. If we biopsy, if somebody is better and I do a heart biopsy and somebody who had cardiac disease, I don't think that I won't find cardiac disease anymore. I do think that the organs can compensate, the kidneys especially, especially if you're one of the majority of patients with kidney disease has a lot of protein loss in the kidneys, and then your kidneys can compensate and get better. The nervous system sometimes gets better, sometimes doesn't. The autonomic dysfunction, orthostatic hypotension, often gets better when we but I don't want to say that we have our own capacity to remove amyloid from our organs.
Awesome, thank you. Moving on to David, I just want to remind everybody, we've got quite a few people in the queue, so please keep your questions to a one question. And David, you're up.
Thanks, Dan. Thanks, Dr. Landau. I just wanted to get your thoughts on sonrotoclax. I met with my professor yesterday with the view to going on a trial, and she was talking about, in Australia, and she was talking about a sonrotoclax trial, and she basically, the words were, in her words to me, were that basically that venetoclax wasn't quite as effective as they were hoping in the medical field, and that this new sonrotoclax is the next big thing to help for cardiac AL. So I just want to get your thoughts on that for everybody on the Zoom.
I think that's being studied in a variety of trials, but I myself don't have experience with it. I think that if it has a higher response, I think venetoclax is very effective for a subset of patients. And so this might be, in the test tube, it looks like it's more effective. What that translates and who will respond, or will everybody with translocation 1114 respond better instead of, our response rates with venetoclax are on the order of 60 to 70%, which is pretty good, but if it's pretty good if you're in the 60 to 70%, but it's not good if you're in the 30%. If we could drive the number higher with sonrotoclax, then we're doing better. But I don't have good experience I can't really speak to the drug itself.
That's all right. Thanks very much. Thanks for your time. Cheers. Thank you.
Cheryl, you're up.
Great, thanks. I have a two-part question, but it's one question. And it's related to CAR T. And you had told one of the women earlier who asked a question that if your light chains, I guess, are normal, that you're not a candidate for the CAR T trial. But what about if your light chains are normal, but you still have monoclonal protein that is showing up?
You have an M spike.
Yes.
If you have something circulating that we know that, or if you have bone marrow plasma cells, if we know that you don't have just organ dysfunction, because
Got it.
if you have an active hematologic disease, depending on the trial, depending on the eligibility, if you have an M spike or if you have a free light chain that's measurable, the problem also is in these clinical trials, to get a drug approved, you have to show that somebody responds. If you don't have any measurable disease, these drug companies don't allow you to go on these clinical trials because they can't prove that you responded.
Okay, yeah, because I've had, my light chains have always been normal, but I've always had an M spike, and the Cybor D and Dara has not done the trick. The Revlimid and the other one that's just like it have not done the trick. So I'm talking to my doctor about that. And then I was curious about, and hopefully this will be interesting to most people on here, what that process is. What is the CAR T, experience?
Yeah, so CAR T cell is, so we actually engineer your own cells. So you have circulating lymphocytes, and we anybody who's undergone a stem cell transplant knows that we can collect your cells through your vein or through a catheter with a machine that looks like a dialysis machine. For a stem cell transplant, we have to get the stem cells, which live in your bone marrow, and we have to use drugs to mobilize your stem cells out of the bone marrow to circulate in your blood. But when we collect cells for CAR T, we simply collect the circulating cells, so we don't have to do any stimulation. We collect your cells, we send them to a company. The company produces this antibody that they can integrate into your own cells, and then the cells come back to us. And so the process, once we get the cells, we give you 3 days of chemotherapy to suppress your own immune system so they won't reject those cells. And then the cells are delivered, and there is this cytokine release syndrome because the cells are really effective at targeting the abnormal plasma cells, and it makes an inflammatory reaction, but that's very manageable. And then
So it's not as intense as a stem cell transplant, both from the harvesting of it as well as like the chemo that you go through and all that. Right.
because it doesn't have the high dose, the stem cell transplant is tough because you really, your goal is to get rid of every last cancer cell with the use of high dose chemotherapy, and it gets rid of all the innocent bystanders, like all your blood counts, your whole GI tract. But the chemotherapy that's associated with this is much milder. You could have a little bit of upset stomach, a little bit of low counts, but not anywhere close to
Great.
the stem
Thank you.
cell transplant days.
Thank you.
Yeah,
Thank
very
you,
helpful.
Dr. Landau. Thank you, Cheryl. Hey, everybody, in respect of Dr. Landau, we are going to go through Sally Cox will be our last question for today's session. And so, Elaine, you are on.
Thank you. 2017, I had amyloidosis in my kidney, had a stem cell transplant, very good partial response. 4 years later, I needed another level of treatment, which was Velcade. I've been in remission for 4 years. What are you finding is the average number of years of being in remission, and is that getting better?
Yeah, that's really hard because we actually don't have the data. So we have the data with Velcade-based therapy, and that's probably 4.5 years. But that's not everybody at the 4.5 year mark progresses. It's half the people progress before 4.5 years. I have somebody who, got Velcade in 2008 and is still in remission and has never relapsed. With Dara, that's even a more powerful drug, but that was only approved in 2021 and it's only 2025. So we've only had 4 years of data. I don't know how long people are going to stay in remission with Dara-based therapy. And I just told you CAR T cells are even more powerful, and I have no idea how long patients will stay in remission. But even in myeloma, there was just a report, and myeloma tends to have a very proliferative relapsing. And we gave CAR T cells to the sickest of the sick of the myeloma patients, and 30% of them at 5 years are now still in remission. So that is more powerful than any in a very, very sick population, which really had these weren't patients who responded to any other treatment. So it's changing the paradigm, but not for everybody, but for a good number of patients.
Thank you.
Thank you, Elaine. Ken Wasser. You're on mute, Ken. Ken, you're on mute. Okay, let's go to June. We'll come back to you, Ken. We'll go back. June, you're on.
Hi there. This is actually for Grant Mittman, my husband.
Hi.
Hi.
I don't have my computer with me. So I'm a patient. I am a HATTR V50M, but I also have Vexus, and I was wondering if anybody else had Vexus, which is a bone marrow thing that involves over-vascularization and immune response. So my first question, or first part of my question,
You're asking
have you heard of Vexus? Does anyone who has?
you're asking the population here?
Yeah, the population or you?
And me, no, you know, again, I treat very few patients with TTR amyloid because I'm at
Oh,
Royal
okay.
Kettering. At a cancer center, so I tend to see all the people with the bone marrow type of amyloidosis.
Okay, I just got back for 2 days at NIH, and they asked me that question. I didn't know the answer.
So far, he's the only person they know of who has both the amyloidosis and also Vexus. Have you heard of Vexus?
Which are both protein misfolding diseases.
Yes, but again, it's very rare, so I can't say, you know, if we
Well,
think
okay,
R
I
is
just
rare,
need to,
AL is rare, that's even,
yeah, I wanted to throw that out there in case any of this large group had knew. And
that's a fair question, because when you have something rare, you never know.
yeah, and the other part is I have terrible pain in my feet, and I've tried just about everything, gabapentin, Lyrica, Cymbalta, oxycarbazepine, lidocaine infusion,
Oxycontin.
Contin. Yeah, is there anything new out there for pain?
I'm sorry, I wish,
All right, well, okay, those are my two most pressing questions.
Grant, if you want to re-ask that question in the chat, maybe someone else has some feedback.
Okay, I will do that. Thank you so much for putting this on, and
You're welcome.
it was good to throw it out to big community about the Vexus, because maybe somebody knew, and I have the top doctor for Vexus, but surprisingly, NIH does absolutely nothing with amyloidosis. So,
But he thinks the two are somehow related.
but he thinks they're related.
Yeah.
All right, thank you, Grant. Ken.
We're
you're on.
Sorry, I was on mute. I have to ask you a two-part question. One is, how long do you keep people on DARA? And the other question is, when somebody relapses with 1114 translocation, how do you decide between CAR T and venetoclax?
So daratumumab, I follow the Andromeda trial, which is 2 years. What? Yes. And then when somebody relapses, if they have a translocation 1114 and had never had venetoclax, I would typically try that first because it's an oral pill. It's, you know, it could be very effective and it's very easy to take. You know, CAR T cell, although I do think that it's hugely effective and much simpler than a stem cell transplant, it still requires an investment, right? You still, I mean, investment not financially, but you still have to go through a procedure. It's very different than taking a pill. If you were on venetoclax and then relapsed from there, or didn't respond to venetoclax, I think a CAR T cell would be an appropriate, or a bispecific antibody, which we didn't discuss. That's another whole, I think we need a whole other session on new novel drugs for plasma cell diseases, because there's a lot. But I think that if you were one of those super responders to venetoclax and then you went off it and then relapse several years later, I think you can also go back on venetoclax.
All right, thank you.
Awesome. Thank you. We've got 3 more people in the queue, Dr. Landau. Sally Cox will be our last question. Charles, you're up.
Thank you, doctor. I have peripheral neuropathy, and I was on Velcade. I'm now on. My peripheral neuropathy, and that it may very well hinder my recovery. Your thoughts, please, on that.
You were interrupted. So is the question that you have amyloid and you have peripheral neuropathy, and then you were on Velcade and it worsened your peripheral neuropathy?
Yeah, that's what my oncologist believes that it has damaged it in terms of any recovery much at all. I'm now on Dara. So I just wondered what your
Yeah,
thought
so
was,
yeah,
peripheral neuropathy relative to Velcade.
yes, peripheral neuropathy can get significantly worse on Velcade, not for everybody, but it does. And it's a challenging problem to have. We have lots of medications that can reverse the pain, not reverse, or manage the pain associated with the peripheral neuropathy. We don't have good treatment for everybody, as we just heard from Grant, that his peripheral neuropathy is not well managed with any of the usual drugs that we treat. Patients who develop peripheral neuropathy from Velcade can get better over time, but it takes a long, long time. And usually the numbness or the people call it annoying sensation doesn't ever necessarily go, patients live with their neuropathy. It's hopefully not as painful as it once was with either drugs or over time, but it tends to continue to be annoying. And
Thank you, Dr. Landau.
Thank you.
Roberta, you're up.
I want to call everyone's attention to the chat. I have put two lengthy, they have their URL addresses to promote. One is the amyloidosis support group. It has webinars, for instance. One is coming up this Saturday, and it's for ATTR. And a month from today, August the 23rd, they're going to have a webinar for AL, amyloidosis. So I want to call your attention to just Google amyloidosis support groups, and you'll find a lot of things on their website. For instance, last week, a lady spoke about, I believe she was in Wyoming, where would she find a doctor to go to? On that amyloidosis support group page, there's a map. You click on your state and a list comes up, maybe in your state or a surrounding state, of treatment centers. The other website I want to reference is the Amyloidosis Research Consortium. What I see there is every 6 months, they will have an update about clinical trials. For instance, January and this month, they're going to feature the ATTR clinical trials. They'll tell you whether they're phase 1, 2, or 3, if they're recruiting, what some of the results have been. For the AL patients, their cycle is spring to fall. So in April, they had a similar webinar about their clinical trials, and it's recorded at their website. So you would anticipate in October they will give you another update about clinical trials. So again, those two are in the chat. I would recommend that you look for those.
All right. Thank you, Roberta. Sally Cox.
Yeah, hi, Dan. Thank you, doctor. Really appreciate the time today. Quick question, back to the topic du jour. The one slide that, doctor, you showed with the fiber depleters on it, there was the AT02 noted, and that didn't get a red X through it.
oh yes,
Is that still active in a trial?
no, I got a red X.
It got red X too? All right, and that one was the pan amyloid, is that correct? So
Yeah,
there,
that was the pan amyloid that was being done in Australia.
okay,
And we were all very hopeful that it was going to be the most effective, and
so was I.
very disappointed.
All right, thank you.
All right. We've got to let Dr. Landau go. We've got
I do want to say there are still companies developing their drugs. I'm disappointed and discouraged, but not hopeful for the future. We're living, we're learning, we're making strides in all kinds of ways. I'm not saying that the depleters they may come for a comeback, and there may be subsets of patients who do benefit. We just don't have that data right now. It's not a panacea, and I'm disappointed for that reason, but I'm still hopeful, and there's still plenty of people trying to figure this out, and we will not stop trying.
Awesome. Thank you. Thank you, Sally. Dr. Landau, if you can just hold with us for just about 2 more minutes. I just want to I'll make a couple announcements. We've got someone with their hand up, Al Mardori. And if you could, I've just put my email address in the chat. If you want to copy that email, send me the question and I'll do my best to find out the answer for you. Secondly, in the chat box is a registration for next week's session. We got a great guest on. His name is Bill. He's got a very long last name, and I'm not really good at pronouncing it. But I met him when I went to Capitol Hill to talk about rare diseases and get some things pushed through on the bill. And he is an expert on what's called PBMs. That's called Pharmacy Benefit Managers. And he's going to talk about that's really the middleman between the drug companies and the pharmacy, and how sometimes your drug might be disapproved and what kind of steps you can take to reenact that situation. So it's really valuable education. I encourage you to sign up for next week. And lastly, QB, I did not get your email. So if you can put that in the chat, that would be great. So if everybody could take off their mute button real quick, we're going to do I would like to, first of all, Dr. Landau, thank you for an incredible presentation and for your heart and your soul and the things you do for the amyloidosis community. And please, everybody, give Dr. Landau a big round of applause. Awesome.
Bravo, bravo.
Yes. And then lastly, Dr. Landau, we end each session with a series, just some thoughts of gratitude. We're all in this fight with amyloidosis. And what I tell our attendees every week is that we didn't choose this fight, but we can choose how to fight it. And one way to do is just always find gratitude, because when you're in gratitude, you're not able to be anyplace else. And studies show that when you're grateful and in a good mood and attempting to be positive, it actually improves the healing process. And so I just want to, as we leave here today, have everybody think about something you're grateful for. Again, being on this call, being able to connect with other patients, maybe someone in your family, just the family that loves and cares about you, or maybe that great walk you took today in the sunshine. And we all have things to be grateful for. So, Dr. Landau.
I'm grateful for Dr. Landau.
Hey. So everybody, thank you very much for being a part of our great sessions. It wouldn't happen without you. And please register for next week. I will see you same time, same place. And again, Dr. Landau, thank you so much. It was incredible. So see you, everybody. See you next week.
Thank you.
Bye.
Thank you.
Thank you so
Bye-bye. See you next time.
Thank you. Thank you.